Kia ora koutou, no mai haere mai to tonight's Goodfellow webinar. My name's Katie McCulloch. I'm a nurse practitioner working in Tamaki Makaurau. Our focus tonight is premenstrual syndrome, PMS, and premenstrual dysphoric disorder, PMDD. This webinar will explore hormonal changes throughout the menstrual cycle and their impact on physical and emotional well-being. We'll distinguish normal physiological shifts from disruptive symptoms linked to PMS and PMDD, explaining their classification, diagnosis, and underlying hormonal and psychosocial causes. The session will also cover a range of management strategies from lifestyle adjustments to medical and psychological treatments. Our presenter tonight is coming to us from the other side of the world and very early in the morning, Dr. Nicky Keay. Nicky's an endocrinologist and honorary clinical lecturer at the University College of London. She lectures and researches in areas of exercise and endocrinology with publications in this field. She's a medical advisor to the Scottish Ballet, and she's currently working with colleagues at the University College London, backed by leading women's health organisations, to develop a UK menopause support program. Thank you so much for being with us here tonight, Nicky, and for you today, I should say. Over to you.
Thank you so much. It's not too early, to be fair, but it is still early-ish. So thank you very much for that kind introduction, Katie. So yeah, thank you so much for inviting me back, indeed. Today I want to, as Katie said, talk about PMS and PMDD. So, and these are sort of the topics I intend to cover. So give you a little bit of a background about the menstrual cycle in general, just to orientate us in that regard. Talk about the diagnosis of these conditions, the classification, what exactly is driving these conditions, and then of course the management. So what do we do for these individual women experiencing these challenges? So we have to talk about hormones to begin with, because this is, as I will explain, this is really the etiology, the driving factor behind PMS and PMDD. So we all know hormones are internal chemical messengers transported in the bloodstream. What they actually do, you get a clue from the derivation from ancient Greek of the word hormone, which means setting in motion. So these internal chemical messengers, once they arrive at a cell, they enter the cell and they go to the nucleus and they direct the expression of DNA. And in that way, they set in motion various biological responses to these hormones. And of course, in that way, their hormones are essential for both physical and mental health. So if we bear that in mind as we go on and describe what happens in the menstrual cycle, then this will explain a lot of the etiology of PMS and PMDD. So talking of the menstrual cycle, here we have the beautiful and exquisite, unique hormone choreography of the menstrual cycle, which occurs hopefully every single menstrual cycle of a woman's menstruating years. So I won't go necessarily through all the little points. I'm sure you're familiar with this, but just the highlight points are that you can see we divide the menstrual cycle, as you know, into two phases: the follicular phase, the luteal phase. And the follicular phase, you can see after menstruation has completed, shedding of the endometrial lining. The follicular phase, then we have this ramping up of estradiol, which causes the LH surge and ovulation. So this is the very rare example in the endocrine system where there's actually positive feedback here. So rising levels of a hormone drives the increase in levels of another hormone. So this is unusual, but this is what happens. So you can see the late follicular phase is dominated by estradiol. Once ovulation has occurred, the remnants of the follicle converts to the corpus luteum, which releases progesterone. And so this is what happens in the luteal phase. You can see there is a second increase in estradiol, but really it's progesterone that's ruling the roost in that phase of the cycle. So when we come on describe PMS and PMDD, then this will sort of make this kind of is underlying what's going on, this fluctuation in these hormones. A few important points to make. Although I presented this as a beautiful symmetrical graph, in reality, there's a lot of variation, particularly in the follicular phase. We did a recent research study published which shows that actually the variation in the length of the menstrual cycle is down to the variation in the length of the follicular phase. Once ovulation's occurred, the corpus luteum is formed, then actually that luteal phase is pretty fixed at about 12 days or so. But so there's a lot of variation in the exact timing for individual women and indeed from cycle to cycle. So inter and intra-woman variability. Also, the levels of these hormones will vary from woman to woman. And this is really the third and most crucial point, especially in the context of what I'm going to go on and talk about, is that every woman will have her own personal biological response to these hormones. So even if this level of progesterone is the same in two women during the luteal phase, one will say she feels fine and the other will say she is experiencing PMS and PMDD. So that's really, really crucial. And also this will explain why you don't make a diagnosis of PMS and PMDD on the levels of the hormones. It's really the biological response of the individual woman to these hormone levels, which is the key thing. The menstrual cycle, as you know, it's totally normal and indeed healthy physiology, with the periods, the menstruation itself, being a free monthly medical check, as I call it, an indicator, a barometer of internal healthy hormones. And certainly I deal a lot, it was mentioned I'm the medical advisor to Scottish Ballet. I work a lot with athletes and dancers, and just to emphasize that the menstrual cycle is normal and healthy, and if the menstrual cycle stops, then whatever the level of exercise, it's important to look into that. A few facts and figures about the menstrual cycle, just to remind you. Menarche is when periods start, average age being 12, primary amenorrhea if periods had not started by the age of 15. The menstrual cycle length can be variable, as I've mentioned already, a lot of variation. Nevertheless, if a woman has less than 9 periods per year, this is oligomenorrhea, and secondary amenorrhea is where there's a cessation of the menstrual cycle for 3 months or more. The woman's not pregnant, by the way, in a previous regulating regular menstruating woman. And menopause is when the ovaries retire, periods stop, and the average age is 51. So what's so good about these ovarian hormones? Estradiol, most active form for estrogen, and progesterone. Well, I could have just done the whole talk on this, but I will just summarize here and say these hormones are super important for these particular areas of physiology of the biological system. So musculoskeletal health. We know, of course, there's a big increase in poor bone health, both at menopause and in women who experience long duration of amenorrhea. Cardiovascular health, again, we know that the risk of cardiovascular health massively increases after menopause because of the decline in these ovarian hormones, which are cardioprotective. Neurological function, we know these hormones, and this is an important one where we come on to discuss PMS in more detail, important for mood, cognitive function. And we know that when these hormones are at low levels, for example, in individuals with secondary amenorrhea due to REDS, relative energy deficiency in sport, or indeed at the time of menopause, we know that there can be mood issues there. Also important for gastrointestinal health. So looking at the cycle and going back to these fluctuations in the hormones, there are some key points to notice in each phase, and some challenges for women during the menstrual cycle. Of course, menstruation itself, it can be painful. You're losing blood as well. And so we know that it's advisable to keep well hydrated, maintain good iron intake. And also there's evidence to show that doing some gentle exercise is actually helpful for those menstrual cycle cramps. Anti-inflammatories can also help. But as with all situations, physiological responses to the menstrual cycle, or the fluctuations of the hormones more precisely, there are things, sort of self-help things we can do, but it's when these symptoms become really problematic that there's a problem. So, for example, menstruation being case in point. If it's particularly painful, then of course we're thinking, is this endometriosis? If we've done all the sort of simple self-help approaches first. The late follicular phase, there was a big increase in estradiol, and so there has been some suggestions that this may favor the doing intense exercise training here, but there's a lot of individual variation in this, and indeed there's also been some evidence to show maybe there's an increased risk of anterior cruciate ligament injury, ACL. Again, mixed results, but I go back to that point I made that every woman will have different timing and different biological response to her hormones. What about the luteal phase? This is when progesterone is high, and progesterone has the effect of increasing metabolic rate, and this is the principle of the ovulation thermometer, by the way, because it will increase just slightly the basal body temperature. And so action points for this, because progesterone has increased the metabolic rate, it's important for the woman to realize that she might need to slightly increase her carbohydrate intake. Again, a lot of variation. How much more? Some people say just an extra banana a day. Some people say actually more than that. It will be variable. Progesterone's also got a catabolic effect, so increasing protein intake is important. So those are the physiological changes that we would expect to occur during the menstrual cycle. So the crucial thing is how do we distinguish these expected physiological changes to these fluxes in hormones during the menstrual cycle? How do we distinguish these physiological effects, which are part of the menstrual cycle, which one can anticipate and deal with, to those that actually are problematic? And this is really the crucial thing. As it says on this slide, up to 40% of women will report some of the things I've said. They might feel, particularly in the luteal phase, a little bit sluggish, more hungry. And so how do we distinguish that from PMS and PMDD? And the clue is that the self-help things that I've suggested don't work. And there's actually impaired function for these women, and this impairs their quality of life. So it's certainly a lot more than Hippocrates originally described. I found this description of Hippocrates, I thought it was brilliant. Lassitude, heaviness of the head. So if that lassitude and heaviness of the head becomes really problematic, such that it's impairing the quality of life of the woman, that is when we're sort of considering that this is more than just a physiological effect that the woman can hopefully manage to some extent. And so how to diagnose this is essentially the extent of these symptoms interfering with daily life. And also it's important to document this. So it's a cluster of symptoms which occur in a cyclical fashion in those 2 weeks. You remember I said the luteal phase was pretty set at 12, 14 days before menstruation. So it's got to be that it's a frequent recurrence, and it's got to be specific to the menstrual cycle. You know, we can all feel a little bit not so good from day to day, but is it on a cyclical basis that this is occurring? That is really the crucial thing, both in terms of physical symptoms, you know, feeling tired, hot and bothered, etc., but also psychological, because remember, these hormones cross the blood-brain barrier, have an effect on the brain. So that is really the diagnosis. It is a clinical diagnosis. And also crucially that these symptoms, cyclical symptoms, resolve with menstruation. So that is the definition. That's what you really need to find out. Is this PMS or is it PMDD? These are the steps you have to go through in terms of what are the symptoms, when are they occurring, the timing, and the resolution with menstruation. That's the key thing. So what are these symptoms I'm talking about? So they sort of cover these 3 areas, I think. So psychological symptoms, so mood swings, as you can see here, I won't read them all out, depression, irritability, poor performance, so cognitive function as well will suffer, attention, etc. Physical symptoms, bloating, breast tenderness, irritable bowel. See, this is all making sense now. We think about how these hormones affect the physiology. And also, particularly with cognitive, I think this is the extra element level to it, inability to focus. So those are some of the symptoms that we're talking about. And there is, you're probably familiar with this diary. Sorry, it hasn't reproduced very well on the slide, but you get the gist. So you invite the woman to fill out these symptoms according to the days of the menstrual cycle. You can see there at the top, and then it's sort of a tick box thing. Let's see which of these symptoms she's experiencing. Is it with the timing? Is it relating to that luteal phase of the cycle? So then you have this nice record. There are other tools available. You can see here I've mentioned some of them, and apparently there's also an app now available on iPhone. So really you have to gather the information. This is like an old-fashioned clinical diagnosis. We don't rely on blood tests, so it's really getting that history, getting the documentation of what the woman's experiencing. That is really the key thing. So that biological response of the hormones for that individual woman, what's that looking like? And so how do we distinguish between PMS and PMDD? Essentially, it's one of severity. So you can see here from this this table, and by the way, I highly recommend this paper I'm referencing a lot here during this talk. It's really excellent. It's got all the latest updates. So the difference between PMS PMDD is that of severity, and you can see there in terms of the symptoms, and especially PMDD, it's more weighted towards that emotional side of the symptoms. And there is a diagnosis according to DSM-5 criteria. And, you know, the PMS will go through the management, obviously, shortly, but the PMDD is definitely something that might require more intensive, detailed input, and, you know, probably will need pharmacological treatment. So that's really the distinction between PMS and PMDD. It's one of severity, and therefore management will be directed accordingly. So the DSM-5 criteria that I mentioned for a PMDD, so as you say, as I've mentioned already, it's really crucial that it's this timing of these symptoms, which is really the key to this, okay? It's specifically to the luteal phase resolved with menstruation. I'll show you the symptoms in the next slide, but as it says here, you've got to have a minimum of 5 out of the 11 with at least one of the core symptoms. We'll have a look at those in detail in a moment. Point D is that it is impacting the quality of life, the day-to-day living of the woman. That's really the crucial thing. That's your measure of the severity of it. And point E is not just an underlying medical condition. It's specific and related in that temporal way to the menstrual cycle. Of course, not a side effect of other medications or substance use, etc. And it's got to be prospective, because I'm sure you're aware of this, and we all are. We kind of forget, unless we document it, we kind of recalling, oh, when was it that I was feeling really low? You can misinterpret that. So it has to be a prospective recording of those symptoms, so that you could, for at least 2 consecutive cycles, so you can really see that clear pattern emerging, hopefully. These are the DSM criteria, the core symptoms and additional symptoms. So just having a quick look through this slide, you can see these are the core symptoms. And to reiterate that PMDD, there's a lot of emphasis placed on that psychological element. So you can see here libido, I can't say the word, variation in mood. That's easier to say. And, you know, quite low mood at times, depressed mood, feeling of hopelessness, etc. And that's really important to, of course, identify that and ask about that, get information on mood. But equally, it can also be anxiety, can swing between being low mood and sort of very anxious as well. So those are the core symptoms. And remember, to be diagnosed with PMDD, you must have at least one of those core symptoms. And then these are the other additional symptoms. The total has got to be 5, by the way. And so we have additional symptoms here. Difficulty concentrating, we mentioned lack of energy, motivation, food cravings, which is not unusual during the luteal phase because of the metabolic effect of progesterone, but nevertheless really quite extreme, if I put it like that, food cravings, out of control, problems with sleep, and then those physical things, the breast tenderness, nostalgia, pains, headaches, etc. So I think that's actually, if you're not familiar with this table, this box, I advise you, do recommend that you have a good look at that. So the diagnostic approach to PMDD, as I've been emphasizing throughout, is that you've got to have that prospective recording of these symptoms over at least 2 cycles, and make sure there's nothing else going on. We mentioned, Katie mentioned that at the beginning, biopsychosocial factors. As I say, we can all be low and anxious for a variety of reasons, but just inquiring what else is going on in that person's life, if there's been a bereavement or traumatic event, that could of course have a bearing on your diagnosis. And yeah, as it says here, important to have that prospective record of the symptoms before you start any treatment. Otherwise it's going to be very difficult to assess if the treatment's been effective. So classification of these PMS and PMDD. So there's the classic PMS. So as I've been emphasizing, related specifically to the menstrual cycle, ovulatory cycles, in the luteal phase, when there's that higher level of progesterone and also a relatively high level of estrogen. So that is classic PMS associated with ovulatory cycles, and then there's resolution of the symptoms once these hormones drop and menstruation starts. So that's the sort of the classical one that I've been sort of focusing on, I suppose, up to this point. There are variants, I think, that it's important to be aware of. There's premenstrual exacerbation. So there's an underlying condition, as mentioned here, of epilepsy or something like this, and then this underlying condition gets worse during the luteal phase. There's also this very interesting variant, non-ovulatory PMS, where actually ovulation isn't occurring, for example, in PCOS or indeed in perimenopause, but there's still the symptoms are still presenting, even though ovulation, or more specifically, a high level of progesterone is being produced in the luteal phase, because there is a condition called subclinical ovulatory disturbances. So the woman is reporting having menstruation, but it might not be accompanied with a robust luteal phase, i.e. sort of a decent production of progesterone, if I can put it like that. So I think that this is what we're talking about here, non-ovulatory situations, or subclinical ovulatory disturbances, I think is probably the more up-to-date term, if I can suggest that. There's progesterone-induced PMS, so this could be from an external source of progestogen, whether this is in terms of the contraceptive pill or coming from HRT. And again, it will depend on the way you're taking, of course, these medications. If it's continuously continuous HRT or sequential, but nevertheless it could be essentially due to the external progestogen from whatever source. You can also have PMS without menstruation. So this is where the ovaries are there, but you haven't got the uterus isn't there. So hysterectomy, essentially, we're talking about, or where menstruation isn't occurring because you got something like a Mirena coil there. So the ovaries are still releasing hormones in that cyclical fashion, but you don't have the sort of evidence of it, if I can put it that way. You're not having menstruation. So that really is, I think that's very interesting. And this is a slightly complex diagram, but it essentially summarizes what I've just said. So this, in a visual way, explains what I've just said. So if we start here, this is, as it says here, mild physiological responses to the fluctuation in hormones. Okay, so that's what that would look like, affecting the quality of life, but manageable. Okay, this is the sort of classic PMS during the ovulatory cycles, and you can see it's a question of degree compared to physiological responses. This is actually now going to impact the woman's quality of life. This is where there's premenstrual exacerbation, so there's an underlying condition already. So already there's a sort of an underlying problem or challenge, and this gets even worse during the luteal phase. This is where PMS is occurring, but there isn't menstruation to sort of orientate you. Okay, so this could be someone who has had a hysterectomy, for example. Okay, so that would that's that one. This is when it's PMS is induced due to an external progesterone. So you can see there it will follow a nice cyclical pattern. And this is actually when it's not anything to do with PMS or PMDD, where actually there's an underlying psychological condition. So yeah, hopefully that visual little representation, it was helpful for me to sort of think about it and explain, to tease apart what we're exactly talking about. So that's what PMS is. That's PMDD. So that's how to diagnose it and the various classifications of it. So what's causing this? So we go back to hormones setting in motion and the biological response of these hormones. And that is really, and the evidence we have that it's definitely due to hormone fluctuations is that when there are no female fluctuations, PMS does not occur. So we're talking children don't get PMS, obviously, because their menstrual cycle hasn't started yet. And similarly, after menopause or after oophorectomy, you don't get these symptoms. So we know it's definitely down to the female hormone fluctuations. But what exactly is it? That is the underlying, the etiology. Which hormones are we talking about? And it is probably, well, again, the sort of clue is in the fact that it always occurs in the luteal phase. It's to do with progesterone, and more precisely, the metabolites of progesterone that occur, the GABAergic metabolites like allopregnenolone. And the evidence we have for this from functional magnetic resonance imaging, we can see that that's, these areas light up in these particular sections of the brain during PMS. We also know that GABA receptors are associated with psychological disorders. We also know that progesterone tends to be associated with depressed mood, whereas estrogen has the opposite effect, has an antidepressant effect. So this is all evidence for progesterone, that increase in progesterone during the luteal phase, which seems to be the underlying cause. There's of course also genetic susceptibility mentioned here, and also pre-existing, psychological factors. Going back to this biopsychosocial model, previous psychological stressors are linked to women being more likely to develop PMS or indeed PMDD. And focusing again on this sensitivity, individual biological response to the hormones, this is interesting triad, which was first described actually some years ago by Mr. Studd and Nick Keay. And we know that there's this cluster of women who are more likely to experience PMS, also more likely to experience postnatal depression, and more troublesome perimenopausal symptoms. And when are these? So this is this triad of ovarian hormone sensitivity. And this also corresponds to the times when the hormones are in the greatest state of flux. So looking at the female hormone odyssey, everyone will start here as a child. All hormone levels are low. The pituitary hormones, FSH, the ovarian hormones, response hormones, estradiol and progesterone low. Then we reach menarche. We have the menstrual cycle we've been describing in detail. There's also physiological amenorrhea, pregnancy, high levels of estrogen and progesterone produced by the placenta. And then over here we go down to the ovaries retiring. Yes, that's menopause. So these are distinct boxes, if you will, times of the pattern of the female hormones, but it's when there's this transition from one to the other. So this is the teenage years. Teenagers can be experience, challenges of the menstrual cycle starting off, including PMS. We talked about postnatal depression, so when the hormones switch from there to there. So that's the other bit, that's that bit of the second arm of the triad, and this is the third one, when the hormones go from this to this, because this isn't these transitions, it's the transitions. They're not on-off switches. So it's the transitions, the changes in the patterns of the menstrual cycle hormones. That's when you're more likely to experience PMS or indeed PMDD. So that explains that. And this also emphasizes that point. The times when the ovarian hormones are in greatest state of flux are here. So during puberty, when the menstrual cycle is kicking off, it's not perfect. It needs several dress rehearsals before that's a really good coordination of the hormones. And then similarly here, this bit is kind of like a reverse puberty over here. This is perimenopause, of course. And in both cases, please notice that actually it's the estradiol which picks up first, and it's the estradiol which maintains and sustains last. And then it's the progesterone, which is the one that has a little bit of a lag. But it's this when there's a sort of discoordination between estrogen and progesterone, both in adolescence and in perimenopause. Guess what? One of the symptoms of perimenopause is worsening of PMS. So this goes back to the hormones, that individual sensitivity, the interaction between the ovarian hormones as being the underlying etiology for PMS and PMDD. So what are we going to do about it? So far, hopefully now I've made it clear how you diagnose, the different classifications, the underlying mechanisms, the individual biological sensitivity, especially during times of hormone flux. And so now what are we going to do? So the first and most important thing is this: ensure an adequate safety net. So, PMDD, it's a really potentially serious condition. As I've stated here, up to 86% of women with PMDD have considered suicide, and some of them, these women, have actually followed through. So that's really a pretty concerning statistic right there. So absolutely, as it's the fluctuations of hormones that are the underlying cause etiology, then of course we need to address that. But for these women for whom we have a concern, then it's really super important to have this multidisciplinary team around, coordinated with mental health colleagues, because that is one of the key diagnostic criteria for PMDD. So it's really important to make that clear at the very beginning when you're trying to guide the woman on the best management strategies, to have that backup early on, I would say. So just bear that in mind. So here we're going to go through each of these treatment strategies, this algorithm in detail, but just to summarize it here. The aim is we've got to try and reduce the effects of those hormonal fluctuations, which is what causes PMS, PMDD. And ultimately, I guess we need to try and mitigate or to some degree suppress these hormonal fluctuations if that is the driving factor behind these conditions. So first line, actually it goes back, I'm going to call it self-help, I suppose, but is what I mentioned at the very beginning. Looking to exercise, absolutely, we have evidence that that's helpful. CBT can be helpful. I'm going to talk about these other alternative herbal preparations, Agnus castus. Mixed reviews, if I can put it like that, but certainly in my experience, actually, I've found, and I know Mr. Nick Keay, who is a leading light in terms of all things PMS, he actually feels that Agnus castus can be really helpful. And frankly, it's the usual thing. If it's not going to cause harm, then actually it's a really helpful strand to your management strategies. In addition to lifestyle, then the next thing is to consider the newer generation combined contraceptive pills, which are going to suppress those hormonal fluctuations. And also here, SSRIs, either continuous or at the very least in the luteal phase. So that's the first line. Second line, we're going to talk about relatively high dose HRT, which suppresses internal hormonal fluctuations. And ideally, the progestogen component of this is probably going to be more effective if it's continuous to avoid that fluctuation in hormones, and SSRIs maybe at a higher dose. Third line is suppression, well, quite drastic, if I could put it that way, suppression of the hypothalamic pituitary ovarian axis via GnRH analogues, and giving add-back HRT, ideally continuous, I think. And then fourth line is surgery. Sounds quite drastic, but sometimes, needs must. So this would include abdominal hysterectomy and bilateral oophorectomy, and then giving HRT subsequent to that. Because remember, as I said at the top of this slide, it's the hormonal fluctuations which are driving these conditions. So that's what we're trying to address, try and smooth out these fluctuations or remove them entirely. So let's looking a little bit more detail at each of those strands of management. So the first line ones, lifestyle, absolutely. Exercise, we know it increases, the feel-good hormone, serotonin, and so that definitely is really helpful. And if the woman is not already doing regular exercise, of course, advise her to, or if she is feeling really struggling to do exercise, again, encouraging and saying, actually, just getting out there and doing some exercise, ideally outside, because we've got, sunlight is very good for mood, we know. So, advising on exercise, whatever her current exercise patterns are, either let's get exercising on a more regular basis, or at very least, let's try and support to get out there and try and do something, even if it's a walk outside in the sun or getting up and doing a walk in the morning. Just making those little changes can really, really help. Nutrition. I mentioned previously that the effect of progesterone is to increase metabolic rate. So make sure the woman is keeping on top of her energy demands, and you are more dependent on complex carbohydrate as an energy source. So, reassuring the woman not to feel guilty if she is feeling hungrier. This is natural, this is normal physiology, and having that extra banana can be really, really helpful. Complex carbohydrates, slow release, that's really the key thing. Increased protein requirement, because progesterone has a catabolic effect. And also it's been recommended to increase tryptophan-rich diet because that's helpful in terms of increasing feel-good hormone serotonin. Evidence that vitamin D and calcium can sometimes help, and vitamin D, as we all know, certainly if you live in the UK, well, we don't have much sun at all. Vitamin D, that's the main source of this, is the action of sunlight on the skin, and certainly in countries where you're in short supply of the sunlight, then taking vitamin D supplementation is, well, it's kind of like a no-brainer, if I can put it that way, because not only will it help with general well-being, but we also know that it can help in terms of bone health, muscle recovery from eccentric loaded, and indeed immunity. Evening primrose oil, there is some evidence, a little bit patchy, I accept, in terms of breast tenderness. Chasteberry, which I've already mentioned, that's a little picture of it. beautiful, isn't it? That's chasteberry on the right, in purple. And so, yeah, that's taking that during the luteal phase. As I say, there are mixed reviews if you look at the literature, but I think it's certainly worth trying, and I found success with it with women with, PMS. Really good quality product. That's really key. Really, ideally with the traditional herb trademark, so it's good quality. CBT, cognitive behavioral therapy, can also be helpful. So those are some sort of initial starting points in terms of advice for PMS. I mentioned then there's also the hormonal approach, and so suppressing ovulation with new generation combined oral contraceptive pill. These are some of the suggested products. So we have Zoli, which has estradiol in it, the real stuff, if I can put it like that, rather than the ethinyl, the estradiol. And Zoli has this type of progestogen component. Or you could try one of these contraceptive pills, Yasmin. That's got progesterone component is drosperidone. And how to take it? If we're trying to smooth out or suppress the ovarian hormone fluctuations, then actually taking either continuously or at the very least with a very short interval-free period time would be advisable. And then also combining with low-dose SSRIs in the luteal phase, or you could consider it in a continuous fashion. And just to remind you why the contraceptive pill is helpful for PMS and PMDD is because this is the effect of the contraceptive pill on hormones. So in the background, you can see very faint. That's the usual fluctuation of the menstrual cycle hormones. Whoops, sorry. But the contraceptive pill is specifically, by the way, it's the progestogen component that suppresses ovulation, by the way. That's why Zoli works, because although it's got estradiol, the real stuff, not ethinyl estradiol, it's got a synthetic progestogen, and that causes suppression of ovulation, which in these conditions actually is really helpful because you want to calm down that fluctuation in the ovarian hormones. In terms of SSRIs, I won't read out all the names on this list. You can see them for yourself. But these are the various ones that are suggested and the dosages. There are some side effects, of course. And I, of course, stepwise approach, starting initially just with the luteal phase. And then if you're doing a continuous regime, then you will have to, if you're going to come off, advise the woman to come off these, then it's important to taper down to avoid withdrawal. Second line, hormonal medication management. So this is with HRT at a relatively high dose to suppress ovulation. So, for example, estradiol delivered transdermally, but of course with endometrial protection, and so this could be either an intrauterine device like the Mirena coil, or you could give daily micronized progesterone, e.g. progestogen, 100 milligrams. I think that's quite a good choice because, as we know, this micronized progesterone can help with sleep. So that's why you must always take it last thing at night. So that actually, I would say, would be my personal preferred combination. And high dose SSRIs, luteal phase continuous, probably you're moving to at this point. Third line management is another form of ovarian suppression, a sort of severe one, if I can put it like that, with GnRH analogues. And in this case, it's important to give back hormones in terms of HRT. Most likely you're going to do continuous, like we mentioned already, either patches or gel, estradiol with micronized progesterone, like we mentioned, most likely continuous. Important to check bone health. I would suggest before you start treatment, get a record of, the BMD, in particular the Z-score of the lumbar spine. If the woman's under 40, that's what you're really looking at. And then you might want to keep an eye on that just to make sure there hasn't been any decline. Although the good news is that bone is very, very sensitive to estradiol. So if you're providing give back HRT, hopefully that will be bone protective and be okay. And then fourth line is, you've gone through all this list. And then, especially women with PMDD, especially if she's got a suicidal intent or attempts, then, surgery can actually be literally a lifesaver. And so this would be total hysterectomy and the bilateral oophorectomy, because remember, it's the fluctuations, the production of the ovarian hormones, which kicks off PMS and PMDD. And so in that case, in a similar way, you will need to give back hormones in terms of HRT, same regime. And probably in this case, you will need to add in testosterone, as in any woman who has an oophorectomy before the natural age of menopause. If she's had a hysterectomy, you don't necessarily need to give the progestogen component for endometrial protection, because it's no longer there. And in terms of, we know that if you give HRT before the age of menopause in a woman who has had bilateral oophorectomy, or indeed experiences POI, then we know this does not increase the risk of breast cancer, by the way, so you can reassure the woman on that front. And in any case, it's thought to be the progestogen component of HRT, which might be the cause of increased risk of breast cancer. And if you don't need to give it because you've done a hysterectomy, actually, that's fine. Same thing, important to give a check on bone health. Hopefully it will be fine, because bone is very sensitive to estrogen, like I said, but still important to have that, do the DEXA before you operate or start any ovarian suppression. So I think that's, so just to wrap up, hopefully this has been helpful and interesting. Looking forward to your questions. So I've taken you through the background, reminding you the importance of hormones. Hormone setting in motion. Hormone is the goddess of effort, energy, and action. There's a big fluctuation in hormones over the menstrual cycle. Very important for women's health, but this can also lead to some challenges beyond physiological effects and challenges. It can also contribute to PMS and PMDD. The difference between PMS and PMDD being that of severity, and especially PMDD in terms of the mental health aspect. We talked about the various classifications, variants of PMS that can be possible. The mechanisms, ultimately, is the individual sensitivity to these ovarian hormones, especially at times of ovarian hormone flux. Remember that estrogen triad that I showed you. And then management goes through this stepwise approach. Lifestyle, always important. Medical, hormonal, and non-hormonal indeed. And then surgical. And then to remind you of that, important about that, multidisciplinary, the support that you will need for a woman with PMDD. There's some references for you, and also just to mention, I hope you'll allow me to give a blatant publicity for the books I've written. This was my first book 2 years ago, Hormones, Health and Human Potential, and then more recently I've published Myths of Menopause at the end of last year. And I talk a little bit more about PMS and other things in these books. So I will stop sharing now. So thank you, Katie. Thanks to everyone for your attention. I look forward to questions.
There's quite a few questions coming in about why the new generation COCPs. Over.
Well, basically, they're less clunky. I have to put it that way. They're lower dose in general, right? I mean, of course, the aim in this context of giving the COCP is to suppress ovulation, but you don't need massive high doses. So that's one thing. And also the ones that have got kinder forms, if I can put it that way, of estrogen, especially if it's the real thing, like Zoli. It's not ethinyl estradiol, by the way, because remember, if you take any sex steroid hormone, the liver has to process it. So if you give it, so that's why you want a lower dose. You don't want to induce a whole load of liver enzymes anyway. And also, if it is body identical or molecularly identical, more precisely, then again, you can understand it's going to have potentially less side effects. So that's why it's the estrogen bit of it is the real thing, if I can put it like that, low dose. And also the drospiridone in the other ones, the Zoli that I mentioned, again, that's a kinder, if I can put it that way, progestogen, less androgenic side effects, because this is a whole different talk, by the way. But there's so many types of progestogen, and they fall into the ones which are very molecularly similar to what you produce yourself, the C21, carbon C21, and then there's the more androgenic ones with those side effects and mineralocorticoid side effects, the C19. So again, it's the new generation are lower dose and more sophisticated, if I could put it like that, rather, and less clunky, less dirty. I don't know how to say it exactly. So that's why. Anyway, but and also, by the way, when I'm saying all of this isn't just my opinion. I'm just trying to give the explanation behind it. Those are the guidelines, those are the recommendations, but I'm trying to give you the explanation to why.
Yeah, thank you. So with Yasmin, you obviously have a higher dose of the ethanol estradiol. Would you wouldn't really want to go for a low 20 or anything like that, would you? Would that not?
I think that it's, if it does what it says on the packet, if it suppresses ovulation, it's like anything in medicine, you want the lowest effective dose. And the purpose in this situation is to suppress ovulation. So if you can do that with a low dose, with a nice, clean, type of ovarian hormone, I'm going to go for that every time.
It's I guess in New Zealand we struggle with, I mean, probably in the UK it's very similar in terms of funding and what we have.
I know Zoli is tricky to get hold of here. Recently I found that as well. So I think Claria or whatever it's called, I think that's that one also is sort of newer generation, I think. So you're going to have to, if I can put it, shop around. You're going to have to look and see what's available, but just look at exactly what is the type of estradiol in it, what's the type of progestogen agent in it. So those are those two things, and also the lowest possible dose, because the lowest possible dose will work because it's licensed for ovarian, so licensed for contraception, for suppression. So you don't have to, will it suppress ovulation? Well, it has to, because it's been tested for that. So I think you're just going to have to see, match up practicality, what's available with what you're trying to achieve. So you're just going to have to, yeah, it's the same anywhere, I'm afraid. Same here as well. You're just going to have to do your best.
I mean, I guess it's very common for us to have to swap people around until we find, even if
Exactly. Yes, exactly. So quite those what I've suggested is the guideline, but then you will come across women who just, even though you think you've selected the best one for them, it actually turns out not to be, because they've got this individual sensitivity to hormone. So yeah, you're just going to have to go with it. And if you're giving it for this particular reason of PMS or PMDD, then this is why it's so crucial with that symptom recording thing. You've recorded what their symptoms were before, you start the treatment, you see what the effect is. You go through the symptoms, have they improved, yes or no? Right? And then you can, adjust according to the clinical outcome.
for those who are unable to take combined oral contraceptives, so using a progesterone only, progestogen, can't use my words tonight, progestogen on pill, there we go. So, I mean, a lot of people are talking about Cerazette. It's recently been funded here in New Zealand. It's a suppression
Yep.
dose that we use. Would that be useful, or do we want the estrogen? So it's a tricky one.
I think it's okay, so long as it's a continuous one, Cerazette. I mean, the thing is, the problem you're running into now is that the side effect of the exogenous progestogen. You don't know what the individual sensitivity to that is. So you might even make it worse. But again, I think it's one of those things you have to try and see, because you're right, it does suppress ovulation. So in that sense, in that argument, it would stop the internal fluctuation of the hormone. So that ticks that box. But if the type of progestogen in the Cerazette itself is going to cause problems and side effects, then you're no better off. So I'm afraid you're going to just have to try it. But that's why the Mirena coil sometimes can be helpful, because it's marketed as being just a local thing, right? Although there is some debate, does it suppress ovulation or not? So again, it's a really difficult one. So you might put the Mirena coil in. She doesn't have periods, but the ovaries might still be, pumping out hormones. So that actually might not be the solution either. So I'm just trying to argue through this. So actually, so I think that Cerazette is worth a try.
Yeah.
But have a low, threshold review, because if you have to be honest. It's always being honest with the patient, isn't it? Saying, look, I'm not sure, I don't know, but this is the principle, that if you take Cerazette, it will suppress the ovulation, suppress the fluctuation of the hormones, which is driving your PMS. But I honestly don't know, and you truly don't, if this type of progesterone will suit you or not. So, and then she might turn around and say, sure, I understand, I'm willing to try that. Or she might say, well, in that case, no, forget that, I don't want to do it. So it's that discussion with the woman and being honest about it. I think that's the key thing. So that would be my practical approach.
Brilliant. And I guess your management sort of cascade started with combined oral and then maybe trial low dose SSRIs. So theoretically, you could do Cerazette with a low dose SSRI to sort of kind of counter.
Well, yeah, exactly. You can see exactly.
Yeah.
And then but I would probably do the Cerazette by itself,
Yeah.
if you're doing it logically. And then if she comes back and says, well, actually it's a bit problematic, then you could add in that low dose, probably in this case continuous SSRI. And so again, you're absolutely right. It's this stepwise approach which is the key thing. But I think that communication with the woman, and it is a team effort, literally. And you don't have to say, it's not because you don't know, we know what the theory is, but then you just be honest and say every woman is different and whatever, and you're recognizing that. And actually, in my experience, patients are really, when they hear that, they're really reassured that you are treating them as an individual, So the algorithm, the guideline is there, but then you have to tailor it according to the individual.
Someone just made a comment before about they're getting quite a few people asking them to have their cortisol levels tested. Is there any relevance to this? Is the hormone level of any true value in the absence of any other typical adrenal symptoms?
No, don't waste that. I mean, I know there's a big trend. Oh, yes. Anyway, listen, the thing is, cortisol, as we all know, has a diurnal variation. So, of course, we should measure it ideally 1 hour after waking, or more precisely when the lab's open, which is why typically we say 9 a.m. cortisol, by the way. Anyway, so you can measure that, sure, if you want to, but, and it's important for diagnosis, don't get me wrong. If you suspect Addison's or Cushing's, of course you must do that, right? But really, because it is so variable, and there are other things that are suggested for a lot of money. You can do salivary cortisol 24-hour collection, blah blah blah, and you get this curve, and what does that mean? Da, 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 da. But I'm not convinced, to be absolutely honest. I think sticking to the basic principles, fundamentals, is, when we're talking specifically about PMS, or actually indeed probably most other endocrine related conditions or situations, it's not really going to add anything more. And guess what? It's probably going to add a heck of a lot of anxiety. If the person says they're not sleeping well and they're anxious, I can tell you right now, the cortisol, it won't, when I say high, I mean high in the range. Not at a Cushing level, but, so I think it can actually be a source of anxiety. Then you do the measurement, and how do you interpret that? Then what are you going to say? And then the person, in my experience, gets in a real flack. Oh, because it's a little bit high, da da da, what does this mean? It's like, so, and anyway, as I said at the beginning, specifically for PMS, PMDD, measuring hormone levels, any hormone levels, I would suggest, is not helpful, because it's the individual biological response, other than ruling out an underlying medical condition. So I want to emphasize that. Cortisol for Anderson's Cushing's, sure. By the way, if we're really going to take it that far, let's talk about thyroid function. Right? overactive thyroid is going to cause anxiety, is it not? Or concentration, right? So but you're gonna know that from, taking that clinical history. You're gonna, get some idea if you think you do need to do thyroid function, just to rule it out, okay? But in general, for this particular condition, measuring hormone levels is not actually recommended. And by the way, it's just the same as, perimenopause. We mustn't diagnose perimenopause on blood tests, as we all know, right? It's on symptoms. This is the same thing. It's on symptoms is the key thing. But use your discretion if you really are concerned that this could be a thyroid condition, if you really are concerned it's an adrenal problem, if you really are concerned, I mean, actually having a very low vitamin D, by the way, can make you feel really down. So I'm not saying never do a blood test. You have to kind of use your clinical judgment if you want to rule out something. But if for general management, it's not going to be really informative.
I'm glad that you mentioned the thyroid function, because I guess part of my next question was going to focus on dual diagnoses or differential diagnoses. And when someone's coming to you for the first time and they're telling you the symptoms, I mean, most of it you can sort of pick up. This sounds like this is happening, but is there anything that you don't like, any red flags that you don't want to miss? And I guess obviously suicide is a big red flag, but is there any other conditions that we want to sort of rule in, rule out whilst we're doing this assessment with people?
Yeah, well, I think the symptoms, remembering it's cyclical symptoms. So if someone's got a overactive thyroid, they're kind of probably going to be a bit jittery throughout their cycle. Maybe a little bit worse during the luteal phase, that premenstrual exacerbation thing. So absolutely, if you got that clinical suspicion, this person is feeling anxious all the time during the whole duration of their menstrual cycle, maybe getting worse during the luteal phase, then absolutely I would have no hesitation doing a thyroid function test. It's not very expensive. So the main differentials I would say would be thyroid conditions. I did see one question flashing up about ADHD. Yeah, I have to be, I'm not a specialist in ADHD, so, but from what I do know, and from talks I've heard from Dr. Nick Panay, who is, as I said, the real go-to guru in this matter, he actually presented a really interesting case of a young girl who was experiencing, PMDD from the symptoms, problems concentrating at school, blah, 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 but actually she then had the additional diagnosis of ADHD, right? So that is definitely something, but as I said, I have to be honest, I'm not an expert in this. But again, if you're doing all the things we've discussed, you're taking the history, you're taking that diary of the symptoms, you've maybe excluded the thyroid function, you excluded thyroid issue because you thought, well, I should, because she's also feeling anxious and difficulty concentrating at other times. And then actually this is where that multidisciplinary approach is super important. This is outside your expertise, as it is in mine, I'll be absolutely honest, right? If I have a woman with this, but I think I'm just like, something doesn't exactly fit, then I will have no hesitation, sending that email, making that call to a colleague who is, knows more about ADHD than me, to get, to see if that's a contributing factor and if that needs a separate medication. So definitely, we're hearing more and more about ADHD. So, if it doesn't all quite fit, there's something, you just got that feeling, that clinical instinct, you've done everything, but there's this extra thing you can't quite explain, then I would always advise, I always ring up, phone a friend, I'm phoning up a colleague and asking their opinion, and whatever. I think that's really the key thing. And you'll feel that, you get that feeling that actually there isn't something that exactly you feel comfortable with. It doesn't exactly fit. There's something extra. So yeah, in that case, I would say absolutely that's something to consider, not as a differential, but maybe as an additional factor. Because you'll have made the diagnosis because of the cyclical symptoms. But if there's something else you feel going on, that's when you need probably advice from a colleague who's a specialist in that area.
Yeah, I guess it sort of covers that sort of premenstrual exacerbation.
Exactly.
Yeah. So there's a couple of questions around chasteberry. So what sort of dosing do you recommend? Do you have a preferred brand? As there are so many natural products and not all of them are created equal.
Right, exactly. Well, my best advice, and this is what I say to patients when I say, look, chasteberry, it's worth a try. I said there is some evidence, some not, whatever. But the key thing is to make sure you are selecting the best quality. So not necessarily the cheapest. Um, and certainly in the UK, I think maybe international, I'm not sure. But looking for the one that's got that, it's a trademark, traditional herbal remedy or something, I think it's called, sort of a triangle sign, checking it's really good quality. And I had this exact question from a patient, oh, what dose? I said, actually, you have to take the advice of the manufacturer because they're all different, you see. So, I mean, maybe something in the region of 2 to 4 milligrams, but please don't exactly quote me on that. But the thing is, make sure it's good quality, the best you can, right? Do some research, not necessarily the cheapest, I'm afraid. And if the product has got some research behind it, that's what I always say. Are they quoting some studies that they've done that they say this is helpful? So really feel confident that it's good quality, and then actually read their recommendations for the dosage, because that's the problem. A herbal preparation, it's not the same as a medicine. A medicine we know is strictly regulated, licensed, blah blah blah, and it's got what it says in it exactly. It's all been from that point of view tested out, clinical trials, etc., etc. But the herbal preparations are a different kettle of fish. They're not exactly like this. So my best recommendation is seek out the best quality you can, and also follow the advice of the dosage. But it will be something in that region. If it's something way more or way less, then it's like you should raise your eyebrows and just check that out.
And pyridoxine for treatment, would you recommend that at all? Or?
Well, again, it's one of those ones with mixed results. But I'm of the opinion that so long as it doesn't cause harm, and again, you're saying to the patient, look, there are mixed reviews. I would say there's probably more robust evidence for the chasteberry than pyridoxine, but still, I would just be absolutely honest and say there are mixed reviews, because I was looking all this up, obviously, before I made this presentation, and yeah, it's got a whole table of X number of studies showed yes, and Y number showed this, and it's like, ugh, like, what's the conclusion? There isn't one. Right? It's really it's this individual response, just as the whole argument with the ACL injury thing. It's a different topic, I know. There will be so many papers saying yes, there is a relationship, others saying no, there isn't, to the late follicular phase. And then if you just think about it, hold on, we're talking about individual biological response. So this is the key thing. So for all these things that I've mentioned, the chasteberry, the pyridoxine, etc., I think that, I am honest with the patient and I say, look, there are mixed reviews. Some it helps, some it doesn't. But I think it's definitely worth trying, because, ultimately we want to try, the principle of medicine is to try and avoid medication unless absolutely necessary. So if it does improve the symptoms using these more other preparations, supplements, whatever, then it's certainly worth trying, I think.
There's a couple of questions around the second line in terms of management. So why is the HRT, MHT second line and not first line? And would you you'd be using it in women of all ages if you're going through this cascade of events, when you wouldn't just be perimenopausal women that you're thinking of?
Correct. Yeah, that's true. I mean, yeah, I would argue I agree with that. I would argue, so I was going to rewrite this algorithm, which I'm not, by the way. I definitely haven't got that. But yeah, there is an argument that wouldn't it be just better to get rid of the contraceptive pill and HRT? But then, of course, these women that we're talking about who are suffering with PMS or PMDD because of hormonal fluctuations, these are of reproductive age, and it covers that side of the coin, doesn't it, you see? So I think that from a purely biological point of view, I suppose you could say, HRT, especially if it's molecular identical, I would argue surely that's better than the contraceptive pill. Yeah, I agree with what people are saying. But you have to bear in mind the age group of women you're going to be suggesting treatment to. And lots of these women may also want contraception, you see. So, but you could argue that actually HRT, you could give the estrogen bit of it, and then you could use the Mirena coil, which covers contraception. So, but I agree with this question, this argument, this line of argument for the question. But as I said, I didn't make the algorithm. But I think it's bearing in mind, in my opinion, I think it's bearing in mind that the age group of the women we're considering. Because, if we give HRT to especially perimenopausal women, we have to say it's not contraceptive, right? So, I guess it's sort of managing both considerations. If the woman wants contraception, and also some women actually find it more acceptable. When I was giving my talk about POI last year, the first line in that situation is HRT, but actually it's argued that some women actually find it, they feel more comfortable. They're of that age to take the contraceptive pill rather than saying, oh, I'm taking HRT, because it does have, rightly or wrongly, the connotation of an older woman. By the way, I'm not saying that that's just what I've heard. That's not my opinion, by the way. I'm just saying that. So I think that's probably why it's in that order. But I totally agree. It could be interchangeable depending on the woman, depending on what she wants. So again, having that open discussion is the key thing, and not showing her all the details of the algorithm, but just laying it out. Look, this is how we're going to approach it. There's this, and she might actually perk up and say, you know what, I don't want the contraceptive pill. I have tried it before and it was awful. And so she might actually say, I want to take the HRT. So again, I think it's having that open discussion is really the important thing.
In terms of women who were using SSRIs if someone's already on an SSRI, do we boost it to that luteal phase? Is that a recommendation? Or what about people who are already on quite a high dose of an SSRI? Again, do we boost above for the luteal phase? Or
So are you thinking about a woman who's already on SSRIs for an underlying condition, or she is anyway, she's already trying it?
Yeah. Or she's already on concurrent condition. Yeah.
Oh, I see what you mean.
Yeah.
Okay. So yeah, probably the dosages, I'm sure you're going to make these slides available to people. So the dosages in that table from the paper I quoted gives you the range of the doses. So yeah, probably you would in that case. I mean, obviously deal with the female hormone side of things, like we've discussed, the contraceptive pill, HRT, whatever it is. And then definitely, as you said, for line 2 onwards, SSRIs are always mentioned. And so if she is already on SSRIs, then yes, there would be leeway within the recommended dosages, of course, to increase that, or even switch. It depends. Is it this particular one that isn't effective? I don't know. So again, I think it's going to be that individual approach, but the general principle of what you're saying is if on the current dose it's not doing the job, then yes, probably going to increase it within the limits of the recommended dose, of course.
Someone's just asking about CBT and its efficacy with PMS and PMDD. You mentioned that one of the risk factors, I guess, or mechanisms relates to a trauma response or some large stress. Is that why CBT is so useful? Because there is potentially that sort of trauma response in the background? Is it? Yeah.
Well, but both. Of course, if the previous trauma experience, of course, that's going to help. But actually, even if that isn't the case, because it's really your response to the symptoms, that's why CBT is also recommended or suggested for perimenopause. Professor Moira Hunter here in the UK done a lot of work on CBT for perimenopause. So in a similar way, it's actually how do you, so you've experienced it. No one's questioning that you experience these symptoms, but it's how do you deal with that? You, to a certain extent, you have a choice. You have a mechanism. How are you going to deal with these? How you're feeling, you see? And so it's CBT, you know, that's really the principle of it, as I understand. Not my area of expertise, but Myra wrote the chapter in my book, so I've read it, and so this is why it works. So it wouldn't be exclusive. So CBT would not be exclusively for women who have had a previous traumatic experience. It would be for all the women, you know. And for some it won't work, and some it will. It's one of those things, you know. But some women find it really useful, and you know, working on the principle that of course, we want to give medication where it's indicated and necessary, but ultimately, you know, we want to keep that the medication low dose and, you know, really targeted and specific. So if CBT means that actually the woman, especially I think we're talking particularly about PMS, finds that that is a really good, you know, helpful strategy, the CBT, you know, that's great. So it's not exclusive to women, is the answer with previous, you know, traumatic experiences. And as I say, it's one of those variable things. Sometimes it's really helpful, sometimes not so, but it's one of those things in your, you know, select range of options and suggestions for the woman.
We are coming very swiftly to the edge of our time, but I just wanted to quickly ask your opinion. So, those for women who we know who are experiencing significant distress with either PMS or particularly PMDD, is it obviously in the back of our mind, we're always going to be thinking for continuing on their journey of care, what's this going to look like for you in perimenopause? And is there something that we sort of want to think about in terms of, do we start MHT? Do we have that conversation with them early because of their erratic hormone cycle?
Yes, well, that triad, you know, of when is PMS or PMDD, when is it at its worst or more likely, it's those times of hormone flux, which are the teenage years, postnatal, and yes, perimenopause. So, you know, women, and that's actually PMS, either worsening of or development of during perimenopause, I'm finding more and more, right?
Yeah.
So, you know, that's one of the early indicators, as we know, you know, one of those list of symptoms. Oh, is your menstrual cycle shortening? Yes. Oh, and how are you feeling before your period? And then, so yeah, I'm afraid it is one of those things that will happen. So yes, I think that it's, again, the woman is prepared. So, you know, if you are dealing with a woman in her 30s or whatever with PMS, PMDD, then yeah, I think I don't, without scaring her, saying, look, you might find some more problems as we move into that time of hormone flux with the perimenopause. But that's great, because then she'll be aware of that. And so, yes, I would have a short, so therefore, yes, I agree with you. I'll be more likely to start or open up that conversation about HRT sooner than later. But certainly, in general, women in perimenopause that you're seeing, I'm seeing that more and more. I suppose now I'm more aware of it, that there is an aggravation of PMS there, or a de novo, like, oh, I never used to have PMS and now I really am. So yes, but that is an indication for HRT, because it's for quality of life in that age group. And the rationale is that it smooths out those hormonal fluctuations. And so that's really the key thing. My lovely colleague Geraldine Pryor in Canada, again, who wrote something for my book, I call her Professor Progesterone, and as I showed you on that chart, it's true that it's actually the progesterone declining. You know, or it's the change of the equilibrium, the estrogen and progesterone, which is kicking off in perimenopause. So just to leave you with a thought, that she's done a lovely study in Canada which shows that actually, rather than giving estrogen and progesterone, you know, in perimenopause, she did a lovely study showing that just giving micronized progesterone by itself improves symptoms, including PMS, by the way. But anyway, or at the very least, the argument is, at least if you give a very low dose of estrogen, it's smoothing it out. because that's the thing in perimenopause. The estrogen's doing great big variations, ups and downs. Progesterone is definitely on the slide. So that's the argument for giving a low dose bit of estrogen, just a little bit. Sandrina gel, if you have it over there, 0.5 milligrams, great. Better than the pump, which is just a meter dose of 1.25 generally or something. Anyway, so that's the slide to slide. So in summary, yes, I would have a lower tolerance, whatever indication for starting HRT sooner than later in perimenopause in general for quality of life, but specifically it will also help if PMS is a symptom. They will definitely help that.
Brilliant. Okay. Honestly, Nikki, that was just such a great talk, and I really enjoyed the Q&A section with you. It's been a really interesting evening. So thank you so much for being with us all tonight. The resources that you shared we'll put on the registration, with the website registration, and we'll send them out to you tomorrow as well, along with a copy of this video. We're extremely lucky to have you come on from all the way around the world, so thank you very much. And just thank you to everyone for joining us tonight. Have a lovely night, everyone. Ka kite.